All right, everybody, welcome to the Compliance Guy Live. I am actually coming to you today from Orlando, Florida at the Ascent ENT Manager annual meeting. So I actually have a live audience here as well. I want to share with all who are joining in online live that we welcome your questions and comments in the chat field. Today, we are talking about the novel coronavirus SARS-CoV-2, which stands for Severe Acute Respiratory Syndrome Coronavirus 2. As part of the discussion, we are talking about natural immunity, efficacy versus adverse effects of the jab, ethical and legal issues as it pertains to physicians refusing to care for patients that have not received the vaccine, employers terminating those who have refused the vaccine, and hospitals now fining employees whose spouses are not vaccinated. I want to be clear. I made requests to multiple physicians who are very vocal on social media, claiming they will not treat patients who refuse vaccine to come onto the podcast to share their view. But all refused for one reason or another. I share this very important fact because I do not want anyone to think this will be a one-sided discussion. And yes, for those of you that are tuning in, you have not reached the wrong show. This is still Sean Weiss. This is still the Compliance Guy, although I am not in a hat and a t-shirt today. It is still my show. Before I get to our panel, I want to say one thing. And I say this with the utmost sincerity. Our frontline healthcare workers are off limits to verbal and physical attacks. These same dedicated, nurturing, compassionate professionals who are there during a time of crisis, holding the hand of patients struggling to take a breath or someone who is taking their last breath, have even been demonized in the media unjustly and are now fearing for their safety when they go to places such as the food store. It is unbelievable to me that these heroes have to change out of their scrubs to ensure their safety prior to entering into a food store. This is unacceptable to me, and it should be to everybody tuning in and listening today. We should not tolerate this type of behavior. Now, due to how large the panel is, we may not be able to take questions, but I will be monitoring them throughout the podcast in the event there are questions that are critical to our discussion. With respect to comments, we welcome all, no matter what your stance is on vaccines. However, I request that you refrain from using profanity or inflammatory statements to stoke a reaction from the panel. I, as you all know, am not a talking head on cable news network. And as such, I am not interested in sound bites, nor am I interested in having this discussion turn into an episode of Jerry Springer. I have engaged with the panelists prior to our go live, and we are all in agreement that this will be conducted professionally and based on facts and professional opinions as opposed to conjecture. This is important because all social media platforms have policies on misinformation, and it should be made clear that all of my guests today are medical doctors, barred attorneys, and highly credentialed data experts. I would hope there will be no censoring of this podcast, and I will do all that I can to ensure compliance with said policies. So now I want to begin by thanking each and every single one of the panel guests for joining on this incredibly important podcast. It is important for all guests logging on via LinkedIn, Facebook, or YouTube Live to understand out of the gate, this is not a political debate. While politics has dominated the COVID-19 discussion, we must turn in times of a public health emergency to science and put aside our political beliefs to work together to find a solution. While there are raging debates about so many things, I want to narrow our focus to the topics previously mentioned. And joining me today from South Africa is Dr. Ian Weinberg, a leading neurosurgeon and neuromodulator and pioneer in the application of psychoneuro-immunology. From Michigan, Dr. Bob Nelson, publisher of The Forum for Healthcare Freedom, a blog and information resource tool dedicated to promoting freedom in healthcare. From Orange County, California, Dr. Alan C. Weinberg, who is a board certified and 3 times recertified as a fellow in the American College of Surgeons and a recipient of multiple awards, including Top Doctors in America, Physician of Excellence, and often named Top Urologist in America. From North Carolina is Alan Frady, disease and reporting guru, managing consultant, auditor, educator for Guidehouse, and a leading global provider of consulting services to the public and commercial markets. And from New Jersey, Brianna Santolli. She is a healthcare and litigation attorney at Riker, Danzig, Scherer, Hyland, and Perretti LLP, one of New Jersey's oldest and largest law firms with beginnings dating to at least 1882. And we are expecting at some point Ron Chapman, Sr. of the Chapman Law Group, an AV-rated litigation firm representing clients across the United States. So now that I have spent an inordinate amount of time reading disclaimers and introducing everybody to our audience, let me address the first question to Dr. Ian Weinberg. Doctor, welcome to the podcast. Thank you for being here today. It is a pleasure to get this opportunity to spend time with you, as it is with all of our guests. So my first question to you is this: are the COVID-19 vaccines experimental? And the reason I ask is due to how fast they were pushed through the vetting process and made available to the public.
I think that we can accept that they are experimental because, well, the very fact that they came onto the market under the experimental banner through the FDA. Also, the studies that were done before rolling it out to the population at large were very limited. And as we see things progress, features emerge that were never divulged at the outset. So just some examples. Initially, it was clearly stated that the vaccine would remain localized to the place of the inoculation, the injection, and that from there, the antigen or epitope would form and the antibodies would then form. And this would be a very controlled situation. But as time has moved on, it's become clearly apparent that this immune complex has not remained localized to the inoculation site. And in very recent studies, we've seen that the spike protein antigen is in full circulation for up to 13 days. So immediately looking at that, that should have been known at the outset. And if it wasn't known at the outset, it's very much an indication of an experimental situation that was not divulged or not known, which is basically the same concept. Initially, it was indicated that the vaccine would be, like all other vaccines, a cure for an illness, an end to a pandemic. But as time has progressed, we've come to see and notice, and it's become clearly apparent that the efficacy of the vaccine has waned to 4 to 6 months. And so that, again, was not in keeping with what the claims were at the outset. Today, we know that it is a 4 to 6 month waning that has, in many cases, required a booster, a third booster. And so the goalposts were moved yet again. And yet again, it was then decided, no, that this is not the cure for the illness. It is not necessarily the end of the pandemic, but it is going to prevent severe illness, serious illness, and death. Well, we're at that point now. I must say, in many cases, yes, it seems to have diminished serious illnesses and death, but yet, every now and then, there is a location in the world where we see a specifically high incidence of vaccinated individuals with severe illnesses and death. And so once again, we turn to the manufacturers and say, how do you account for this situation? So these examples lead me to begin to become concerned about the claims as they are not borne out in our experience as we enter the second year of the pandemic. And so as far as I'm concerned, very much experimental. And I haven't even touched on the adverse reactions. Which are accumulating in the wings as we speak.
And I want to get to those. Yeah, and I want to get to those. But I want to share with our panel, and I want to solicit some feedback on this. According to the Centers for Disease Control, the CDC, this was published and updated on August 19 of 2021. And it's entitled, What We Are Still Learning. And I wonder if this speaks to some of the hesitancy that exists right now for healthcare workers who, we all know, get vaccinated for the flu. They get their pneumococcal vaccines. They get their testing for tuberculosis. They get tested for a whole host of other viruses. But I wonder if what I'm about to share with you contributes to some of the concern or some of the hesitation to engage in the vaccination for COVID-19. And it says, what we are still learning, how well the vaccines protect people with weakened immune systems, including people who take medications that suppress the immune system. We're talking about a lot of patients potentially that are impacted by this. Second, how long COVID-19 vaccines protect people. So to Dr. Ian Weinberg's point, we're seeing waning after the 4 to 6 month point after vaccination. Third, how many people have to be vaccinated against COVID-19 before the population can be considered protected? What they call herd immunity or population immunity. Now, I remember hearing at one point from Dr. Fauci, if I'm not mistaken, dating back to the Trump administration, that it was somewhere in the 70% range that we needed to achieve for vaccination in order to achieve herd immunity. But that number later shifted with Dr. Fauci to where he said, I should have actually stated that it was 90% vaccination of the population in order to achieve population immunity. And the final point that I will make from the CDC is how effective the vaccines are against new variants of the virus that causes COVID-19. And obviously, Alan Frady, I'm going to get to you in just a couple of minutes because I want to talk a little bit about, some of the statistics tied to the Delta variant and the Move, variant. And my understanding is that right now there are approximately 19 additional variants to COVID-19 that we're just scratching the surface on. But to my original question, back to any of the panelists, Dr. Alan Weinberg, Dr. Ian Weinberg, Dr. Bob Nelson, do you believe or do you feel that some of what I've just shared with you from the CDC is leading to the hesitancy of healthcare professionals who are usually pretty well educated on this stuff, leading to their hesitancy of receiving the COVID vaccine?
Alan Weinberg speaking here. I'm not sure why there's hesitancy. I think it's pretty clear that the reason a higher percentage of immunized patients are necessary for herd immunity is because of the more easily transmissible Delta variant. The more transmissible a virus is, the higher the percent needed for herd immunity, as I think measles has proven. I have trouble understanding the resistance. As being someone in medicine, I understand that there's progress, there's change, there's more data, and opinions and facts get modified over time. So I have trouble understanding the hesitancy. I think it's mainly a lack of education and knowledge.
Fair enough. Dr. Nelson. You're on mute, Dr. Nelson.
I would add that it's hard to talk about herd immunity unless you define the vaccine. We have a disease-modifying vaccine here that we're dealing with, and that was the controversy in the beginning. A lot of people said, "Hey, this may not work the way we think it's going to work because it's not a neutralizing vaccine." Plus, you've got a tremendous difference in the way the disease manifests based on age risk. So it's like a hockey stick curve there. So in other words, are we defining herd immunity that nobody gets the infection or nobody gets sick and dies? And so this is a complex thing, and having a very square understanding that this is not a neutralizing vaccine. It doesn't work like the measles vaccine, for instance, I think is important to point out.
Yeah, and and Dr. Nelson, I'll come back to you in a moment. Dr. Weinberg, Ian Weinberg, natural immunity has been a huge topic, and it continues to be a topic, and it's something that is surfacing now even more so with senior leaders within Pfizer Corporation, within some of the other corporations that are producing the vaccines. But I think there's to Dr. Alan Weinberg's point, I think there's a true lack of understanding for what natural immunity is, how it impacts the human body, and what people need to be aware of when it comes to natural immunity versus the vaccine.
So I have a big problem with this. And if you look at the WHO's website, if you look at the outset, when they were speaking about herd immunity, which was sometime in the middle of last year, they were talking about, and their original definitions I've made a copy of, and they're somewhere on one of my blogs, where they stated that herd immunity was the immunity of the population based both on natural infection and immunity as well as vaccine-induced immunity. And sometime towards the end of last year, in November, just at the onset of the beginning of the vaccination, they removed the natural infection component, leaving only the vaccine-induced herd immunity. For me, that's a big problem, because as we've seen, what's borne out is that there is a questionable sustainability of the vaccine-induced immunity. And having seen that, how does that feed into this herd immunity concept when you're having so many breakthrough infections? Yes, I accept that the infections seem to be a lot less severe and possibly cutting down on deaths, but we still have a susceptible population. And can you then state that an individual that has had 2 RNA vaccines contributes to herd immunity when there's such an increasing breakthrough that in fact a 3rd booster was required? So I have a big problem with this whole concept now of herd immunity with a vaccine that is becoming questionable in terms of its sustainability. So yes, I have a big problem with this. And then in terms of hesitancy, well, I think that we ought to question. I think that we need to see what the statistics are. And we look at children, for example, and the incidence of illness is very, very low. And the incidence of adverse reactions is climbing to the point that there is more morbidity associated with the vaccine than there is from the natural infection. And so that's another important thing. And then in the face of natural immunity versus vaccination, where there are several articles that have shown that the natural infection and immunity is much more long-lasting, much more comprehensive, because it feeds on more than one single antigen, the spike antigen. It feeds on 3 others, which also confer immunity. So I have multiple problems here, and as a result, I would absolutely hesitate to subject children from the young years right up to the age of 19 to vaccinations, knowing that the statistics are against them in terms of morbidity. They're higher from the vaccines and getting the natural infection. I would do antibody testing on everybody at the other age groups, and if they have evidence of a previous COVID infection and they have sustainable antibodies, they definitely should not consider getting the antibody because the vaccine, because the statistics show that the boost from natural immunity, from natural infection, to that which you get from the booster on top of the natural immunity is not that significant.
Excellent.
So hence the hesitancies, these are the points that I think are valid reasons for hesitancy.
So, and I want to come back in just a little bit to the pediatric conversation, because I think there's a much larger discussion that has to take place as well. And again, you know, the information, my hope on this podcast today is that we are sharing information that's not being shared in mainstream media, that we are sharing information straight from frontline healthcare workers, from scientists, from well-respected medical professionals and data, data professionals, legal professionals who don't have a political agenda one way or the other, but want people to understand the facts of what's transpired over now almost 18 months. But I want to go to Alan Frady. And Alan, thanks for being here today. Thanks for being patient, and thank you for subjecting yourself to what may be coming down the pike as we talk about this. And I'm jealous because you're wearing what I was hoping to be in today. So I want to talk about the exaggeration of vaccines as it pertains to the Delta variant, and then besides the Delta variant, the Mu. I believe that's how it's pronounced, Mu, the Mu variant. Which one, if any, are showing signs of immunity to these vaccines? And I know you stay on top of this stuff.
Yeah, so first of all, let me just say thanks for having me on, and thanks to all the panelists for this really important discussion that's needed. These are great questions and great topics. We should probably do a little bit of level setting for our listeners who don't follow all of this evidence, and I'll try to do some of that as quickly as possible.
Thank you.
So as of 8 p.m. last night, I'm just following the Bloomberg version of the tracker, worldwide, there's been 6.36 billion vaccines of the three different types. In the United States, a total of 397, which if you're doing the math, that's more vaccines than we have people. But remember, you're not fully vaccinated until you had 2 doses on at least 2 of the 3 that we're using in the United States. So that's where we are. And I haven't looked at this, but I think we're still in this somewhere around 35% unvaccinated, might be a little bit higher. And then there's this group that's kind of the tweeners, where they just have 1 dose and haven't had the second. So with that said, there was a report, and we're talking about immunity escape. Let's first talk about immune duration for a second. So the CDC and the MMR report on September the 24th gave some interesting numbers. Many of you may have already seen these, where the Moderna, Pfizer, well, let me go through them in order. So Moderna is holding its vaccine efficacy at 93%. The Pfizer is 88%, and the single dose Ad26 vector vaccine, which is the Janssen, is at 71%. With some people saying, oh, maybe we need a booster for Janssen. Now, if you specifically want to dig into Delta and some of the variants, surprisingly, it's a lot better than what the news would lead us to believe. So an article actually came out just yesterday, October 4th, in The Lancet, that looked at a retrospective analysis of about 3.5 million people and found that protection against symptomatic infection at 6 months was declining. However, infection against severe disease and hospitalization is not doing as bad, as Dr. Weinberg alluded to. So the decline was quite startling. It went from 88% during the first month all the way down to 47% for mild and moderate symptomatic type infections, the kind that, I'm actually not that concerned about those. But what I was excited about is protection from hospitalizations was holding at 93%. So, if you look at this, and let's talk about Janssen. A study came out on September 26th for that one, showing that it is holding at about 85% effective at reducing hospitalizations in people infected with Delta. Now, granted, that's a preprint that came out in MedRx. And by the way, Sean, I can send you all of the references to all these.
Sure.
If you want to throw them up.
And we'll produce those for our listeners.
Yeah,
Absolutely.
definitely do that. There's a preprint, but a lot of the subject matter experts, the molecular biologists, the PhDs that I follow are fairly favorable about those. And the third one, I think this might be the last one that I'll talk about before I hand it back, was a peer-reviewed study that recently came out in the Lancet. And I'll just sum it up with a statement. They said, to date, none of the studies has provided really credible evidence of a substantially declining protection against severe disease, even where there does appear to be some declines over time in vaccine protection against those mild to moderate infections. So what they're saying is, I think, let me reinterpret that just a little bit. Delta may be punching holes in the suit of armor in terms of increasing amounts of mild and moderate infections, and it certainly does appear to be superior in terms of viral fitness and its ability to displace other viruses. I think that's without question. But it isn't showing a significant amount of immunity escape for those who are already vaccinated in terms of severe disease. So I can't speak from everyone, but I know me personally, I'm more worried about severe disease and hospitalization than I am getting getting my vaccine and then possibly having a mild to moderate. That's great. I'm fine with that, right? But I should point out that the Delta's higher reproductive index, and maybe Mu, we don't know yet. There's not a lot of data that I could find on Mu. But with the Delta's clear higher reproductive index, it has resulted in a kind of a surprising, unprecedented shift in the demographics of those with the worst outcomes, primarily attacking those without vaccination protection. But what's startling about it is that it's occurring in much younger populations than what typically would have been expected. And so it doesn't necessarily, it removed a little bit of that age feature, probably because the older people, did get the first and second doses. And I think that's why we see these shifts. These things are so complicated that you can't just take a 1 and a 1 and try to do an analysis that A causes B, because all around 1 and 1, there is human behavior, there's psychosocial, there is the neurocognitive piece that I know Dr. Weinberg likes to talk about. There's nutrition. There's so many things. There's where you live, the number of daily collisions you have with people who might be infected. There's so many things. Climate, actually, the amount of humidity in the air we can talk about it can affect the reproductive index. Sure. So a lot of people will just try to take one item and do another one and try to draw all sorts of conclusions from that one to one. But it's much more complicated and nuanced to that, in the real world. And with that, I'll hush up and let you hand it back over.
No problem. Brianna, hang tight because I'm about to get to you in just a moment. But there's two things. I want to go first to Dr. Bob Nelson and then to Dr. Alan Weinberg for two quick questions. And then I want to start to shift our conversation to the ethics and the legal issues providers may not be aware that they are creating for themselves in some of these situations. But let me first ask Dr. Nelson. You discussed on your blog several days ago the Norwegian Institute of Public Health, the FHI, made the decision to classify COVID-19 as a respiratory disease that is dangerous or as dangerous as the common flu. And I think this starts to paint somewhat of maybe a little bit of a different picture for folks that are not scientists, that don't follow these things in the way that you as a physician do, the way that Alan does as a statistics guru. And what they are now saying is that they are clarifying this by saying that they realize the pandemic is not over, but that it has entered a new phase whereby COVID-19 is equated with a common respiratory disease, such as the flu or respiratory infection. Can you talk about this? Can you help make heads or tails out of this for those who are trying to better understand the science of what other countries and other regions of the world are now shifting towards with COVID?
Well, I think this piggybacks on what Alan Frady was saying about the severe illness aspect of vaccines. And one of the things, and I'll get to the crux of the matter of the reclassification in a second, but one of the things they pointed out in this article is that those that were in the hospital that had been vaccinated, 40%, I think it was on week 37 of their study, whatever that was. It was, I think, the second week of September. In that situation, 40% had been fully vaccinated, and the average age of death was 80. 55%, only 15 additional percent, had experienced no vaccination. So most of those people did not die. I think that the take home there is that those that got severely ill, and the average age of death was 80. Those that got severely ill were the same ones that probably did not respond well to the vaccine in the first place. So some of the comorbidities and factors that lead to bad outcomes also probably interfere with the way the vaccine works. So, and let's be clear that most people recover most of the time. So, vaccine or not, the vaccine really shines with those who have the highest risk to begin with. You get much more bang for your buck in that situation. Now, as far as the reclassification, I think they're letting the data inform them instead of filtering the data through a hyperbolic, emotional filter, so to speak, or a political lens, and then cherry picking what fits the narrative. They let the data inform them. And what it basically boils down to, in my opinion, is that those at the highest risk are already protected. Most of the people at the highest risk are vaccinated or had the natural infection, or maybe a combination of both. So, in other words, the virus is picking on that part of the population, which only has maybe partial immunity, like the children. And there's a lot of papers, a lot of T-cell research indicating why the children might get milder disease, why they might have such quick immune response in their T cells that have seen some of these similar beta coronaviruses in the early years of their life. But I think, to sum it up, they have realized that there are only a few immune virgins, so to speak, left for the virus to pick on. These are a very low risk group. And then back to Alan's point, it is about disease severity and who ends up in the hospital, who dies. And if we can prevent that, then that's a game changer. And I think Norway has figured that out, that we are at that point where, we can, I wouldn't say relax about it, but I think
take a different approach to how we view the coronavirus.
Exactly. And again, not in an emotional, hyperbolic way, but letting the data inform us rather than the other way around.
So that leads me to Dr. Alan Weinberg. And this is a question that I have for you. And I think, Brianna, this will start to lead us into the discussion from a legal perspective. And I want to try to balance between some of the legal aspect versus some of the clinical stuff. So I'm going to move around a little bit. But Dr. Alan Weinberg, so as a practicing physician, as a surgeon in private practice, what is your position on treating the unvaccinated or those who are vaccinated, but their significant other isn't? Again, I ask you this question as a board certified practicing physician in private practice, because there's been a lot of debate out there about physicians in private practice saying it's my right if I don't want to treat somebody who's unvaccinated or their family member's not vaccinated or what have you. Can you share with us your thoughts on treating the unvaccinated as a physician?
Well, sure, Sean. Thank you. Well, certainly, to segue, I treat patients with bladder cancer who smoke. Smoking is a high-risk endeavor that leads to bladder cancer. I treat them. I don't judge them. Also, I took an oath So yes, I will treat unvaccinated patients, and I try, if I have time, to use the opportunity to educate and try and convince them to be vaccinated. Now, if I see no patients, I'm not at higher risk. The more patients I see, the higher risk I'm at. I think certainly if they're vaccinated or have natural immunity, my increased risk when we do a little social distancing, wear masks, etc., isn't that significant. I have a lot of patients who bring a family member, and if that family member is not vaccinated, I will not allow them in the room. I see no point in increasing my risk really with a non-patient unless the actual patient has some cognitive impairment and needs a family member there. I guess I'm at a slightly increased risk seeing a vaccinated patient who has an unvaccinated significant other, since they can potentially have COVID asymptomatic and pass that on, but I'm willing to take that risk. I will not, though, allow the unvaccinated family member in with the patient. I will see patients who are unvaccinated and again try to use that opportunity to educate them and see what their resistance to vaccination is.
So, and I think that's an outstanding, explanation, and I respect that. And I want to be clear that I am not an anti-vaxxer in any way, shape, or form. I'm actually fully vaccinated. I made that choice because I have heart disease. I have advanced atherosclerosis. I have multiple stents in my heart. I have AFib. So for me, it was extremely important to be able to balance the risk of the unknown down the road for the vaccine versus the potential risk that I faced as somebody with an immunosuppressed system or somebody who was at a higher risk because of my heart disease and being borderline diabetic. As they say, you can't outrun your genetics. And, sometimes you play the hand that you get dealt. But I want to shift to Brianna. And I know for a litigator, I know for an attorney sitting here for 38 minutes, it has been excruciating for you not to be able to chime in. But I'm so grateful to see your smiling face and to have you here. And, for those who don't know you, I think after today's podcast, even though you've been on a prior podcast with me, I think folks are going to have a tremendous amount of understanding for who you are and really a great appreciation for your approach to these topics as a pure jurist. The question that I want to ask, and you, I don't think you're prepared for this one, but I think you are. So I'm gonna kind of walk you through this one a little bit. On September 15th of 2021, the American Medical Association updated their document under ethics, entitled, quote unquote, "Can physicians decline unvaccinated patients?" In general, and this is what it says, in general, no. A physician should not refuse a patient simply because the individual is not vaccinated or declines to be vaccinated. The commitment to care for those who are sick or injured carries with it a duty, to Dr. Ian Weinberg's point, to treat in other circumstances as well, including public health crises, when a physician may face greater than unusual risk to their own safety, health, or life. And this is stated in opinion 8.3. Physician's responsibility for disaster response and preparedness. Nor may a physician ethically turn a patient away based solely on the individual's infectious disease status or for any reason that would constitute discrimination against a class or category of patients, which is outlined in opinion 1.1.2, prospective patients. Can you opine on that for our audience?
Sure. I think there are two different types of duties that we're discussing here. Of course, there is the ethical duty of care that comes with being a physician, but from a legal perspective, there's also a duty of care as well, and that is what can lead to the dreaded malpractice action. when that is violated. So with respect to rendering care or not rendering care for unvaccinated patients, the first breakdown is whether or not the care sought by the patient is emergency or non-emergency care. With respect to emergency care under EMTALA, which is the Emergency Medical Treatment and Labor Act, physicians have to deliver care, this is federal law, to patients who are seeking emergency services, and that's regardless of their status, including insurance status. And of course, aside from EMTALA, that would also expand to any protected class, race, religion, sexuality, gender. Where it gets a little trickier is rendering non-emergency care. And this is a very fact-intensive inquiry. So I could by no means say this is the absolute circumstances where you need to render non-emergency care and when you do not. But, if there is a relationship, a prior doctor-patient relationship, that's a factor, because then you are terminating the relationship and there are certain obligations that come with that as well.
So potentially a physician who takes the position of you're unvaccinated or you have a family member who is unvaccinated, thus, even though you're an established patient, I'm going to refuse to further care for you, could be considered a form of patient abandonment or patient dumping.
Exactly. And, I think what's key for physicians who are going to take that position is to be aware of what your state requirements are in terms of providing notice to a patient that you won't be providing care to unvaccinated people. I think it's akin to if you're closing a practice, you have to give, typically it's 30 days notice in each state as to you're closing your practice, and the physician is supposed to help facilitate the transition from his or her practice to the patient's new practice. 30 days seems to be the amount of time that gives people a reasonable, a month to go find a new physician in the area. As long as you are not denying, unvaccinated people are not a protected class. So in terms of saying, I'm not going to treat unvaccinated people and there's no need for emergency care, and you're not terminating a relationship with the patient, that would seem to be okay legally.
Right.
Ethically, of course, different question, but would you be subject to a malpractice action? Likely not.
Right. So, the very last statement from the American Medical Association on their position from an ethical standpoint, and Dr. Ian Weinberg, I want to come back to you, because it was your blog post that actually spurred this podcast for me. Your blog is really, and some of the reactions, because it got a lot of reaction, is what really drove me to want to explore this different. But the very last statement from the American Medical Association states this, quote, "A patient's vaccination status in and of itself is not sufficient reason ethically to turn that individual away." So to Brianna's point, there's a difference between what is ethically correct or ethically moral versus what is a potential legal pitfall with refusing to care from a patient. I want to go back to you, though, Dr. Ian Weinberg. And I see some comments starting to come in, and I'm grateful, and we'll take a look at these. You took the position of one of great disappointment with your colleagues. And I don't want to put words into your mouth, but you took the position of great disappointment reading comments of physicians stating that they no longer wish to care for patients simply because of their vaccine status. And I'd like for you to elaborate on that a little bit, because I think as a board certified, or well, as a neurosurgeon, as somebody at the top of your game in South Africa, and somebody who people look to around the world for clinical guidance and advice. Can you speak to that a little bit, please, as a clinician?
It boils down to the science. The science in several articles has stated absolutely, categorically and clearly that the viral load and the transmissibility is equal in the fully vaccinated as it is in the unvaccinated. That has been borne out, and that is an absolute fact. That is a scientific fact. Linked to that is your faith in your vaccination that is there to protect you. So if you put those two together, you can't discriminate. There is no room whatsoever for discrimination. Because in fact, the two groups are identical. The figures are very close for the vaccinated spreaders and the unvaccinated spreaders. So there is no room for discrimination with those particular people. And then there is the group that are naturally infected, who have not been vaccinated, who may or may not have immune evidence. Now, I'm not sure how things go in the rest of the world. Here, it is freely available to have your antibody study done, which, by the way, costs a lot less than a PCR study. And if you wanted to take it that extra step amongst the unvaccinated, in other words, denying the science that I've just spoken about, you should be able then, if you are that concerned for your own safety and the safety of your own staff, to be able to ask them to produce evidence of their immune status from a natural infection, which is not played out in the clinical environment, it's not played out in the commercial environment. And so putting all those things together, I state absolutely categorically that based on the sciences, there is no case in favor of discrimination of the individuals in everyday walks of life, and additionally, not in the clinical environment.
Excellent.
Hey, Sean.
Please, go ahead, Dr. Nelson.
Can I jump in? A couple of questions for Brianna and a couple of comments.
Please.
I would agree with what Ian said about the viral load. I think that's been pretty well documented that those are similar in the vaccinated and unvaccinated situations. I guess, let's say Brianna, I want you to speak to this. You say you're somebody with average risk. You're not a child, but you're not 80, right? You've been vaccinated. You're a physician. You've been vaccinated. Or maybe you have good natural immunity. From a legal standpoint, how do you defend? I mean, your risk is minimal either way. You've either got vaccine-induced immunity, natural immunity. If you get a breakthrough infection or a reinfection, you're probably going to get moderate symptoms. Chances are you're probably not going to end up in the hospital. Very, very low chance you're going to die. How would you defend that? I mean, isn't it tantamount to taking care of people that might carry influenza that have not been vaccinated? I mean, how do you justify that risk when you factor everything in and you're not in a high risk group to begin with, or even if you're not immunized, even if you haven't had it, how do you justify that risk from a legal standpoint when it's really no different than being exposed maybe to somebody with influenza?
It's a great question.
Yeah, it is. And I think what's important to note is that there is no legal obligation in terms of taking on a patient. You wouldn't be able to you can't abandon a patient that you never took on, right? So,
well, I'm assuming that it's an established patient or somewhat of an emergency thing. And the other thing related to that is, how do you define emergency? Is a sprained ankle an emergency, or is it only what might deteriorate? I mean, that's the other thing. I mean, through EMTALA, I'm sure there's a lot of gray areas there.
Right. So again, we need to tackle it one type of relationship at a time, just because it is so fact intensive. I think with respect to a patient that you have a pre-existing relationship with, a doctor can terminate a relationship with a patient pre-COVID, pre even this debate, whether it's vaccinated or unvaccinated. There's no obligation for a physician to maintain that relationship. Where the law comes in is, how do you end that relationship? And that's what I was referring to further in terms of the notice and being cooperative in terms of facilitating moving your former patients, things like medical records, to their new provider. So I don't think that you need to justify the risk or lack thereof to a vaccinated physician, as long as you're following those guidelines.
Well, and I'll turn this over to Sean. One more comment. I guess to clarify, my question was that almost no doctor will terminate based on other infectious disease risks. I get, right. And COVID seems to be carved out in this special, and it almost seems, I'm sorry to say this, but it almost seems like it's virtue signaling on a kind of a self-righteous level to me in some situations, unless that doctor is extremely high risk, and then I get it, right? But otherwise, how do we distinguish that risk if you're vaccinated, if you've recovered from the disease, and your average risk to begin with? How would you segregate that risk and differentiate it from the risk of catching the flu, common cold, RSV, hand, foot, and mouth, and any other of the multitude of illnesses that we're exposed to?
I don't know that you can. And for the and Brianna, forgive me for stepping on you. Obviously, we all have different connection speeds from where we are around the world.
No problem.
But I'll absolutely give you time to respond. From my perspective, I don't think you can differentiate that. And I think the reason why COVID has, to your point, Dr. Nelson, been segregated out is because it has been highly politicized, because it has been highly charged, and it's something that didn't necessarily just affect us here in the United States, that it was a global pandemic. And the fact that it has taken on so many different arguments, and it has spurred so much controversy between, healthcare professionals. I mean, we can go back to talk just about the director of the CDC, Dr. Walensky, as an example. She went against a 16-2 vote by a panel of leading healthcare experts, scientists, epidemiologists, infectious disease physicians, who made a decision based on the science and the numbers from people like Alan Frady that produce to say, we don't recommend the boosters for all people. And, I think that's part of it. There was a great comment that came in, and I want to share this with everybody. This is from Gravitational Time Vortex. What a great name. Previously having the virus should qualify as an exemption. I don't know that I can disagree with that. And I don't know that the physicians, the scientists on this panel today would disagree with that either. But the CDC, to their point, doesn't recommend a measles vaccine if you've had the measles. And the same is true for smallpox. So why are we recommending these boosters when we don't recommend the boosters for the flu? Obviously, you have different strains of the flu each year. That's why you have the quad for some years, that you get as the flu shot, or you get, a certain bit of, certain other types of vaccines. Alan, do me a favor, please. You said you have some data on the issue of patients being seen in a private practice. Would you care to talk about that real quick? And then I want to go to Dr. Ian Weinberg, because I want to get your take on some of this as well.
Yeah, thanks, Sean. So this stuff is fun for me. It might not be fun for all of you. I like to get kind of nerdy with this information. So it would be it'd be really nice if we didn't have this. Yes, it's okay. One answer for physicians to decline. No, it's not okay. And it has to be this binary choice between one and the other. It'd be really nice if we had the ability to have a little bit more of a bespoke conversation, a little bit more of a customized approach. So the fun bit of trivia that I ran across was that there's actually a curvilinear association between the amount of respiratory effort that a person's doing and the direct amount of particles around the person. So I think about this issue of physicians not wanting to treat patients who might have COVID in their office. And I think about what problem is it we're trying to solve? Are we trying to protect the provider themselves, or are we trying to protect the patients around the general area? And that's sort of two separate things. And I don't think it's a one size fits all. So let's say that you have a very small office where you can have a lot of collisions and the waiting room is tightly, you can't get that 6 foot or people aren't doing it. And you also have people who have a lot of respiratory effort. So your particular patient population is COPD, for example, asthma, coming in urgently, didn't want to go to the ED, what have you. So a lot of respiratory effort is going to exponentially increase the amount of potential particles in the air. Say you don't have good circulation. So poor circulation can take up to an hour to clear a room, whereas a really good system can clear a room or basically turn a room over in a matter of minutes. So you may have one physician who has a very legitimate reason about not wanting to have immunocompromised, potentially HIV cancer patients mixing with COPD and asthma patients in the same waiting room with poor ventilation and a lot of collisions. And I think that's a legitimate patient safety concern. On the other hand, the most dangerous things that you can do to sort of amplify this up is singing and exercising, right? Or yelling, or maybe one of your respiratory distress. So if a person who is breathing and speaking at normal levels, okay, the research shows that the mask works for about 50 to 60% of that. Okay, so if you also have good spacing and good circulation, then you've eliminated a lot of that risk in terms of boom. I'm basically doing some medical malpractice by allowing my immunocompromised patients. So I think we need to be a little bit more nuanced in all of these discussions. Yeah. In terms of what makes sense. And I don't like these all or none. I'm not for mandates, right? I don't like these all or none. Everybody has to do it or nobody does it. I don't think that works. It has not worked now I said I wouldn't get political, but now I am. It really has not worked through the pandemic, these one size fits all discussions. And I do think we will see, because I know natural immunity came up. If you'll just let me comment on that for one moment. I do think we will see a move into more of a seasonal situation. So as the virus continues to mutate and increases RI, and a lot more people either through vaccination or natural immunity, it's not that COVID equals flu, but what we will see, and it was naive to think it would happen in 6 months. What we will see over a period of time is a situation where, frankly, the virus is no longer novel, right? So a novel virus causes much more problems than something that's endemic and everybody's immune system is seen, and you're not naive to it anymore. So, there's this belief that over time, the crisis will resolve. I think the real question is, will it resolve, but what is the best moves to do between here and there, and how fast will it happen? But I'm not comfortable with the message that physicians should never do this or physicians should always do it. I think you have to look at your particular patient population, your particular office setup, your particular risks, and tailor that in a way that makes sense for the particular, I don't think anyone's really saying we're not going to treat patients in acute distress who need emergency medical care. There may be a few who are saying, I feel like that, but hopefully nobody's actually doing it because, right, as Brianna pointed out, that's a lawsuit. Right. Thanks for letting me jump in with my bit of nerdiness there.
Dr. Alan Weinberg, you've been standing by patiently. I want to open the floor to you, and then Brianna, I want to come back to you, and I want to talk about emergency temporary standards. And then Dr. Ian Weinberg, I have another question for you regarding masks based on some of Alan's information that he was just sharing in a moment. So Dr. Weinberg, Alan Weinberg.
Yes, sir. I actually have a question for Brianna. My understanding with EMTALA was that basically it's any patient who presents to an emergency room setting has to be treated regardless of the issue, but it doesn't really apply in the office private practice setting. Isn't that true? I mean, EMTALA is not really applying in that setting, although I would still treat any patient who presented.
Right. In terms of hospitalized patients who are presenting to emergency rooms in need of emergency care, I would think presumably if a patient presented to a physician's office and needed emergency care, they would then be sent to the hospital and it would then fall under EMTALA.
Once they got to the hospital, right?
Yeah.
Right,
So
right.
I think to your point, Dr. Weinberg, you know, a physician has a duty to stabilize a patient if it's within their skill sets to be able to do so. It is what I've seen from the cases that I've been involved in malpractice cases, the duty of the physician to stabilize the patient while awaiting for transport to an emergency facility such as the hospital. And then, yes, to your point, EMTALA would apply directly at the hospital setting. So I want to go back because to me, I think this is one of the fascinating aspects of what has transpired here in the United States. And that is the issuance of what is referred to as an ETS, an emergency temporary standard. And one of the things that was utilized was OSHA. And OSHA was used to help push out this ETS with regard to vaccines, with regard to certain mandates, because there was the potential, and this was admitted by the current administration, and it's been discussed by legal scholars, it's been discussed by pure constitutionalists, that the potential risk that the administration could have faced by simply ignoring legal precedent and pushing forward under an executive order a mandate such as what was being pushed out would have potentially created significant legal challenges to the administration. Again, I'm not leaning one way or the other. I'm stating the facts. So what was used instead was something called an emergency temporary standard. Brianna, can you, because you'll do a much better job of talking about this than I will, could you please talk about the ETS for our viewers?
Sure. So the emergency temporary standard is what will allow this vaccine mandate that is coming down the pike here. And that gives OSHA the ability to issue the mandate. The standard for doing so is if employees would be in grave danger by conditions presented at their place of work. Here, the grave danger is COVID-19, presumably the transmissibility of the virus, as well as the hundreds of thousands of deaths resulting from COVID-19. And that's what is going to allow OSHA to put out this emergency temporary standard that importantly will only last 6 months. So once that happens, the clock starts ticking, and then it does need to go through a formal rulemaking process. It has to be published in the Federal Register, available for comment and before being finalized. So we'll see what happens with that. But it is the emergency temporary standard that's within the power of OSHA for workplace conditions that would put employees in grave danger.
Excellent. And the last point on that is with an emergency, with an ETS, those are good for approximately 6 months before they are required to go through a formal rulemaking process, which another way of saying being promulgated into the law?
Yes.
Okay. All right. I have just last couple of questions, and I know we've gone just over the hour now. And Dr. Alan Weinberg, I know you don't want to, but you said that you have to go see vaccinated and unvaccinated patients. My friend, I want to express my sincere appreciation and my gratitude that you were willing to take time out of your schedule. For those listening in, Dr. Weinberg actually rescheduled a lot of patients to be able to be on this podcast today. And I just hope you know, and I hope you know that how appreciative and humbled I am for your willingness to do that. I'm sure I'll be getting a bill for those hours, and I will submit that to my CFO to see if I can push that through. And I know you had to buy some earbuds to come into the 21st century to join us today. Send me the bill. I will reimburse you for those as long as they are not more than 99 cents. But thank you for being here today, and God bless you. And thank you for all the wonderful things you do to take care of patients each and every single day.
No bill at all, Sean. Thank you for the chance. I enjoyed it, and meeting everyone else also on the panel.
Take care. Thank you. Okay, so for our panelists, I have just a few more questions, and I think these are, for me, these are really, and hopefully for our listeners, these are really important questions. I want to go back to Dr. Ian Weinberg for just a moment. Now I could just say Dr. Weinberg because I only have one now. So Dr. Weinberg, I want to come back to you, and hearing about the numbers and some of the information that Alan Frady was just providing to us. Do you believe that masks work?
So this is a very emotive question. It's a very emotive subject.
Well, let's move the question towards pediatrics, because I think there is a lot of information out there from the American Academy of Pediatrics, the AAP, really talking about the rate of infection and the rate of mortality for pediatrics. And we're talking about, ages 4 up to 18 years old, right? And I just worry, and let me hold off on worrying. Can you talk a little bit more about the pediatric infection rate and the pediatric mortality rate? Because I know there's a lot of folks out there that, it's been ingrained into them. Your kids have to wear their masks. They have to be masked 8 hours a day at school. They have to be masked everywhere they go. And again, I'm not debating public policy, but I want people to understand the actual statistics, the numbers tied to pediatrics.
Well, there's multiple questions. Let me try and be as honest as possible. First of all,
Please.
I'm not very much involved with the pediatric side of things. And I'm not an authority on the data associated with pediatrics. I do know that in several studies, it appears that the morbidity associated with the vaccine is higher than the morbidity associated with the natural COVID infection. Very specifically, there's a great concern about teenage males, age 15 to 19, with pericarditis, myocarditis as complications to the vaccination as opposed to the natural infection, which are very significant and which are receiving due review at the moment. Getting back to the subject of masks, well, the most superficial studies, and there's been many studies, show that where there's been a high wearing of masks, the incidence of illness has been low. But with the masks, there were many other aspects of behavior that went with it, which was the social distancing and in several cases, lockdown. So that wasn't really very scientific. The mask wearing was just one component. There have been some very interesting studies showing aerosol spray using very, very sophisticated laser testing, which shows that the mask definitely prevents a significant percentage of spread through aerosol if you have even a cloth mask. That's very significant. But bearing in mind that the virus is very small and most masks will let viruses through, even if just through the sides, that particular study was not looking at the barrier against the virus itself. It was looking at the aerosol phenomenon, which carries the virus, and you can obviously contract the virus through your eyes even. The question which arose in the course of my investigation was the subject of viral load. Does a high viral load give rise to a greater incidence of illness? That for me is a critical question. There has been one excellent study done where they used the PCR, but they brought down the cycle thresholds right down to the upper 20s. So they made it much more sensitive, cut out a lot of the false positives. And in that particular study, it was very clear that a higher viral load definitely predisposes to a worse illness outcome. So that was very clear, and that was very much a study in favor of wearing of masks in a high pandemic area, let's put it that way. And then finally, there was one animal study done with hamsters, interestingly, where they put masks on hamsters. A very simple study, and it was very conclusive that hamsters that had masks had a significantly decreased incidence of illness. So that really is the case that I bring to the table, which is in favor of masks as being effective versus being ineffective, and that can add to the debate.
Excellent. Excellent. Brianna, I have one question for you, and then I want to bring Dr. Nelson into the conversation as well to talk a little bit about some of the ETS. There's been a lot of discussion about religious exemptions. The state of New York, it was really interesting. Now, I know you're across the Hudson, right?
Yeah.
So you're on the other side of this. So I can't hold you responsible for anything going on in the Empire State. But the new governor for the state of New York has said that the religious exceptions or exemptions that were extended in New York City under Mayor de Blasio were out of date and they were behind the times. And as such, no longer would the state of New York welcome or consider any religious exceptions. Can you speak to religious exceptions as it relates to vaccinations?
Sure. Well, first, Sean, also, I am admitted to practice in New York, so I may be partially responsible for what's going on across the Hudson as well.
Okay. Well, you may be getting a whole lot of new clients calling you from New York here soon.
Yes. But, I personally, thus far in my practice, have not come across any cases involving a religious exemption with respect to a vaccine. So I can't speak to it from personal experience in terms of handling a case like that. But just in general, immediately I would be concerned about, and I haven't read the announcement from the governor that you just did, but presumably if she is suggesting that religious exemptions don't apply to vaccinations categorically, I would find that difficult to believe. If someone can demonstrate a sincerely held religious belief or practice that would relate to vaccination, and for as many sincerely held religious beliefs, there are some cases out there that are bogus, in terms of trying to get exemptions to things. But to categorically say no, I just don't see how that's going to play out in practice, and I have a feeling it will not.
Yeah, I agree with you. I think there's going to be a lot of challenges to the denial of religious exceptions or exemptions to vaccines. Dr. Nelson, I know that you had some questions, comments with respect to the emergency temporary standards. Let me turn this over to you, please.
Well, I think back to your point, Sean, about not getting into public policy. I'm not sure that's possible, or that we should avoid it. What I mean by that is, I think one of the biggest mistakes that I can see that continually shows consequences, negative consequences, is that we took a defeat the virus at any cause kind of stance when we went into this pandemic. And when you go into something to defeat it at any cost, you will pay any price. And I think public policy, we have to, and I don't want to bring too many other things into the mix, but when you look at public policy, I think it's about the net benefit. And when you have all these unintended downstream consequences for an attempt to, fight the virus or control the virus at any cost, you will pay a big cost. And I think that we have to acknowledge that. The differences between the social and economic costs of, for instance, what Sweden bore versus what many of the other really militant, hardcore lockdown it did, and to what avail, right? I mean, the end result was not that much different in the end.
Well, I agree with you.
With the ETS, I mean, who are we protecting, right? Who is at risk? Who are we protecting? So, like, everybody that needed the vaccine or benefits from the vaccine has had the opportunity to get it. Again, I know there's nuance, and I totally agree with Alan Frady's take on that. We have to look at these things with multiple variants and multiple factors, but who are we protecting? And the religious thing just drives me nuts, because all of these things are downstream from individual sovereignty. And if we let that get polluted, then where's the limiting principle? We have to have guiding principles and limiting principles. And if we can't say as individuals, yes, I want the vaccine, no, I don't, then I think that's a slippery slope.
Understood. Brianna, you were going to say something, please.
Yeah, 2 points that I think you raise a really interesting discussion about public policy. With respect to the emergency temporary standards by OSHA, additionally, thinking about who we're protecting and what is the standard serving, it's based on the number of people at the workplace. But presumably, I work somewhere where there's more than 100 people, but we, for the most part, are in our own individual offices, and there's either a wall or 6 feet between us at all times. And I forget who raised this example before, but of a smaller physician practice where there's a very small waiting room. And if it's under 100 people, then, or any type of workplace under 100 people, then it wouldn't be covered by the emergency temporary stand. Yeah. So in terms of a legal challenge to it, my first thing would be, well, why are we basing this on size and not considering the type of work that's being done? It doesn't seem like it's tailored to what we're trying to achieve.
That's such an outstanding point.
It's just, I'll be interested to see what happens, because there will be legal challenges, of course. So I'm sure there will be many people who raise that. And, and then just my second point in terms of unintended consequences with respect to treating the unvaccinated with access for rural populations to healthcare. It's been and Alan would probably have the data on this much better than I in terms of percentage of rural populations that have been vaccinated as opposed to urban or suburban populations. And it has been lagging across the country. And simultaneously with that, access to rural healthcare is also an issue in this country. And, I found the designated health professional shortage areas as of September 30th, 2021 in this country were 61.27% of the population that was in this health professional shortage area was the rural population. And that's not for, ancillary care. That's primary care. So if the rural population is also lagging in terms of vaccination status, and also in terms of access to quality healthcare, and then presumably to get that healthcare has to drive up to 100 miles, those are other considerations that may affect a physician's decision to not treat the unvaccinated, or even have an effect on whether declining care to unvaccinated people then presents an emergency situation given the circumstances in those areas.
Excellent. All right. So we have actually gone about an hour and 20 minutes. And I know, Dr. Weinberg, you have spent the entire day prior to joining this podcast in surgery, right up until the point we actually went live, just about. While he looks so nice in his suit jacket, the good doctor is still in his surgical scrubs from today. Dr. Nelson, I know you've had a long, busy day as well, and I want to say thank you so much for you taking time to join into this discussion today. Alan Frady, your contributions, your insight, your firsthand knowledge of these numbers and your ability to convey this information to our panel and to all those who are listening out there, I know is greatly appreciated. And to Brianna, thank you so much for joining in and providing legal analysis, providing some guidance in a lay manner that will help those who are not legal scholars, those who don't have a JD after their name, to at least have an understanding at the surface level for what's going on. Before I close out our panel today, are there any other questions for our panel amongst ourselves, or any other comments that you would like to finalize with before we sign off with our viewers?
I'd just like to make one more comment about mandates, or
Please.
a comment about mandates. Mandates have, in my opinion, I think they have very little to do with their virtue and almost everything to do with their power to coerce. In other words, if it wasn't that, if that wasn't the fact, we wouldn't need mandates. So I think as a society, we really want to grapple with those things, and all these other things are downstream from that consideration. And do we sacrifice individual sovereignty on the altar of the public good, or do we really embrace that as something that should be a first principle and a priority?
Outstanding point.
I'd like to second that. I'd like to endorse that. I going back to the sciences, and that's where I go back to, there really is no legitimacy in terms of these vaccination mandates, and it's merely serving as a very, very unwelcome, divisive tool, which is causing a lot more harm than good.
And potentially setting us up with a precedent for what we may not be willing to endure in the future with the next pandemic, which is pretty much assured. All right. So, ladies and gentlemen, again, for those of you, and I've actually been looking, and we've actually had viewers from the UK, from Australia, from South Africa, from Asia, from here in the United States. I can't tell you how grateful and excited I am that you all were willing to join us today in this discussion. I want to commend our panel for having such a professional and top-notch discussion today, sharing facts, sharing their professional insights and opinions, and staying away from the political conjecture and the talking points that you hear on MSNBC, CNN, Fox News, and some of the other cable news networks. I hope that we've been able to bring you valuable information and information that will help you to make better informed decisions, both as an employer, as an employee, and as a contributing member of society. On behalf of myself, Sean Weiss, the Compliance Guy podcast, and my entire crew that works with me each and every single day, I want to say again, thank you to my distinguished panel guest. I want to say thank you to each and every single one of you joining in globally from around the world. And again, as I always say, be good to yourself, but more importantly, be good to each other. And until next time, I'm going to continue to try harder. Thank you so much. Take care, and God bless you all. We'll be back next week with another episode of The Compliance Guy.